30 microns when it's significant. The resolution is 10 microns, but if the difference is 30 microns, it will still pick it up.
See, and most of the machines are like that, so that is the reason that you have to take slightly, like at least 3 maps for every time to see whether you are getting a consistent result, and rather than just go for one map. So that is kind of pretty true for either your Pentacam and Cirrus also.
Whether you are taking a 6mm zone or a 9mm zone, that is also important.
Yeah, this is about 13 microns, 13 millimeters with the AIOC2022, yes, this is maximum. Because the other devices are about 6 microns or now 9 microns with the OptoView, which again, it doesn't go to the complete periphery. Suppose you have peripheral changes, suppose you have like a Tyrion's marginal degeneration, then it's not going to really look at it. I mean, it's going to reflect onto the center, and you may see some central changes, but it's not going to pick up those peripheral changes.
Also, hyperopic LASIK and ccorrections cannot pick up the changes. So we'll move on to the next talk. It's by Dr. KARTHIK SRIPRAKASH. He also completed his long-term cataract and refractive fellowship with us in 2019. He had won Best Paper Award in ACRS 2018, and today and currently he's working as a consultant in Shri Eye Care Eye Hospital in Bangalore. He'll be talking about role of optical quality assessment in refractive surgery. See how your patient sees. Over to you.
Thank you, ma'am. Always an honor and pleasure to be associated with my alma mater. Yes. We've all had this patient who's had an uneventful refractive surgery, and in the early post-operative period, the vision is 6/6, and the patient still complains that the vision is not good. This is a nightmare. We've all had this patient. So I'm going to be talking about a very important thing to see what exactly is happening. Optical quality is a very important and upcoming factor in refractive surgery, since patients' expectations these days are sky high. So coming to optical quality, there are two main determinants which determine optical quality. The first is the aberrations, including the lower and higher order aberrations, including defocus. The second and most important thing is ocular scatter. So the main areas of scatter in post-refractive eyes can have anything to do with the interface, to do with the tear film dryness, or any kind of early media opacities as well. So what scatter does is that it increases the retinal stray light in the point spread function, and this causes significant deterioration on the quality of vision. So we need to objectively analyze the optical quality in these patients, and the analysis should take into consideration the effect of aberrations as well as the effect of scatter. Now, the HD analyzer does just this, and this has an advantage over traditional labrometry techniques, which tend to overestimate the potential visual acuity. So the HD analyzer works on the double pass system, where the first pass is a point source of image, which is corrected by a Badal system for defocus and projected onto the retina. Now, this retinal image is then transmitted and captured through an artificial pupil into a charge-coupled device camera and analyzed. So this gives us the retinal point spread function image, and it is further analyzed by software to give us 3 parameters. The first is the objective scatter index, the second is the modulation transfer function, and the third is the Strel ratio. So what is OSI? The OSI is the objective scatter index, where it is an objective valuation of the intraocular scattered light. So it measures the amount of light outside the point spread function image and compares it to the light at the center of it. Now, thereby, the higher the value of the OSI, the worse is the visual quality. We take an OSI normally to be about 1.5. The second is the modulation transfer function. So this is basically comparing the contrast of any optical system, which is the eye in this case, and compare it to the contrast of a real scene. So this basically gives us the evaluation of a degree of detail that can be distinguished by any optical system. So the maximum MTF, since it's a ratio, is just 1. And as we know that the contrast reduces as the spatial frequency of the image increases. So at one point, the contrast becomes 0 or close to 0. And this is called as the MTF cutoff. So this is the highest spatial frequency which the eye can detect. So therefore, the higher the MTF cutoff, the better the optical quality is. The third parameter is the strain ratio, which is the ratio between the peak intensity of the point spread function image of an abraded eye to the peak intensity of a non-abraded eye. So the higher the value indicates a better optical quality. Now coming to the steps of the optical quality assessment by the HD analyzer, the first and foremost is that the manifest refraction has to be corrected and confirmed to at least the closest 0.12 diopters. Second thing is we always dilate the pupil. So this is because we can use the artificial pupil which is there in the machine to titrate at what pupillary value you would like to check the to check the optical quality. So once we enter the demographic data into the machine, we also enter the manifest refraction. Now the machine itself can correct a large range of spherical equivalents and a small cylinder up to 0.5 diopters. Anything more than that requires corrective lenses which the machine will suggest. The first sequence after entering the manifest refraction is the best focus sequence, where it is necessary. We have to do this before we do any other optical sequence. Now this is necessary to avoid blurring of the double pass images, and the software searches for the best double pass image by sweeping for different spherical refractions to correct the focus. Now the corresponding refraction is displayed along with the best display double pass image that the machine thinks is accurate. After this, we can proceed with the OSI measurement, where 6 double pass images with the best spherical correction is captured. Now, when we monitor these results, when we analyze the results, we see that on the right side bottom corner here, the OSI is displayed in a color-coded manner. Along with that, on the top side of, we have 2 images. The one on the left is basically the ideal image, and the one on the right is exactly what the patient sees. So this is basically the AV simulation which happens when this is the software does it. It basically convolutes the PSF with the original image of a scene. So this is a very good tool in explaining to patients and even understanding how the patient is seeing, so that even they can be counseled better, and even you can also understand how exactly or what the patient is feeling. Although this doesn't take into account the glare and halos, but it still gives us a good understanding of how the patient is seeing. It also displays the MTF after the analysis, which can be either linear or logarithmic, and we also get the MTF value and the strain ratio. The other advantage of this machine is that it analyzes the tear film so that we can check the degradation of the PSF image over time. So, and it also plots the visual quality index in such patients. So what happens is that you can differentiate whether the loss of quality is because of dryness or whether it's because of any other thing which is causing the scatter. Let's go to a couple of examples. So we're just going to be we're going to be doing a couple of cases. So we do this for all patients for us who come for follow-ups, all patients with refractive surgery. So this is a patient who had about a 4.5 diopter power pre-surgery, went in for SMILE. Surgery was uneventful, and on the first post-operative day, we see that the OSI is about 0.4, and in about post-op 1 month, the OSI is 0.3. So this patient, because the OSI is very less, so this patient has enjoyed very good vision from day 1 itself. Now compare this with case 2, who's a patient with PRK. When you see that the pre-op OSI, everything was absolutely uneventful surgery, on post-operative day 5, you see that the OSI is 3.2, the middle image there. And you see that the simulated image of the baby at 1 meter is so blurred. But as the days go by, so at post-op day 15, the OSI has recovered, and at 1 year, the OSI is almost 0.2. Let's look at a third case of LASIK, where pre- and post-operative days, that is especially on post-operative day 5, the OSI is about 1. We'd like it to be less than that, but this is still okay. And at post-op day 30, it's about 0.5. So this capture can you can make the patient understand what to expect between different procedures, so that he can choose what procedure to undergo depending on the time that is taken for healing. And this is another important tool which you can explain. Another case that we saw, a little peculiar case, where we had a 35-year-old female who was planned for both eyes relaxed SMILE. The manifest diffraction in both the eyes was about 1.75 diopters, which corrected to 20/16 preoperatively. Preoperative OSI reports are about 0.3 and 0.5, And on the post-operative day one, surgery was completely uneventful, but the patient reported that the vision is still blurry. When we examined her, we found an unaided distance visual acuity of 20 by 20, which did not improve to more than that. And in the interface, we saw a very mild haze-like picture. So we subjected her to the anterior segment OCT, but it was inconclusive. So we did a HD analyzer for her, and as we see here, the OSI has significantly increased, almost at the yellow zone. So about 2.1 in the right eye and 2.4 in the left eye. So for this patient, we stepped up the topical steroids and asked her to review after 3 days. At the 4th post-operative day, she is improved. She's saying that the blurring is better, but still the OSI is about 1.5. So although so we asked her to continue the topical steroids and review after 1 month. Post 1 month, she's absolutely fine. She says that the vision is absolutely good. Both eyes, the vision is 20 by 16. What she was reading preoperatively, the interface looks absolutely clear, and the patient has been asked to review after 3 months. So to conclude, the optical quality analysis system is becoming more and more indispensable in modern day refractive surgery. The advantages of early detection of deteriorating optical quality and also the preoperative assessment of any kind of pre-existing scatter are invaluable in modern day refractive surgery. The advantage of the non-invasive dry eye assessment as well as the availability of temporal data, objective temporal data for follow-ups and monitoring is extremely important for today's practice. And I feel that it's a very important tool for patient counseling, especially to make them understand objectively, because it's so well represented that how they're supposed to see and how how they and what visual recovery they can expect. Yeah, thank you.